Hello, we are going to go over pediatrics today, pediatrics unit, childhood nutrition, and we're going over three topics today. We're going over failure to thrive, we're going over selected causes of growth delay, and then number three, we're going over selected nutritional disorders. So failure to thrive, growth delay, and selected nutritional disorders. So let's just jump right in. The format that I'll be going over is essentially general characteristics and then specific causes, diagnosis, and then finally treatment. All right. So general characteristics of failure to thrive. So how is it defined? So failure to thrive is defined as a child that is 2 years or younger with weight plotting below 5th percentile for age on more than one occasion, or whose weight crosses two major percentiles downward on a standardized growth grid. So essentially there's a growth plotting curve, and it's this curve, right? And there's an average of 50%, and then there's maybe above average, so maybe at 60 percentile or 95. So you're still, within normal kind of range. But once you fall, if let's say you were in the 50 major percentile, and then you fell 2 major percentiles below that, then you might be considered failure to thrive. And so you may have been at 95, but if you fall 2 major percentiles, that would raise questions in the provider. Why did this patient fall so far, even if they were so high? Even if they're still, maybe they're still at 50 percentile at the end of the 2 major percentile falls, the fact that they fell so much, such a big gap, could indicate failure to thrive. And then the other one that's more straightforward is if they fall below the 5th percentile for their age on more than one occasion. So if it just happens one time, then it could just be an anomaly, right? But if it happens more than once, then you really need to look into that, look into the family history, see if they're feeding the child correctly, if they know how to do that, if there's something else going on in the family. And this is for kids 2 years or younger. All right, so exceptions to this definition, because there are always exceptions, right? What do you think the exceptions are to this definition of failure to thrive? So there are a few. All right, so there are about 5 or 6 of them. And so the first exception to this definition is genetic short stature, which I'll talk about in a few moments. So genetic short stature. Number 2, if there are small for gestational age infants. So if you were our baby and you were born smaller, then it makes sense that you are going to be below average on this growth curve. So it's an exception to this definition because you were born small, so you're on a different percentile than the average baby because you weren't born normal weight, of normal gestational weight. So then your growth curve will always be skewed for a pretty long time. For not a long time, just for a period of time, all right? And then third, preterm infants is also an exception to this definition of failure to thrive. Number 4, Asian infants as well. And 5, overweight infants with decreased rate of weight gain and increased rate of height gain. So overweight infants are born, right? They're large for gestational age, and they have a decreased rate of weight gain, but an increased rate of height gain. So those are those 5 exceptions. And so let me ask you this. Failure to thrive presents in what percent of babies? So it actually presents in 10% of infants and children. What kind of factors is failure to thrive associated with that you can think of? So the answer to that is failure to thrive is most commonly associated with environmental and behavioral factors such as organic causes such as reflux or GERD, renal tubular acidosis, and then acute or chronic infections can also cause failure to thrive as well. All right, so now we're going to go over some specific causes of failure to thrive. All right, so some of these might be intuitive, but it's still good to go over them. So we're just going to jump right in. So one of the causes of failure to thrive is lack of appetite. So this could be caused by anemia, by psychosocial problems, by CNS pathology or central nervous system pathology, chronic infection, or a GI disorder. The second specific cause of failure to thrive is difficulty with ingestion. This kind of makes sense if you, let's say a baby has a normal appetite, but if they can't swallow properly or they have some motility problems with their esophagus or something's wrong there, then yeah, they can present with failure to thrive because they can't ingest enough food or milk to grow properly. And so it can be caused by psychosocial problems, feeding difficulty, cerebral palsy, or other CNS disorders, dyspnea, or that's shortness of breath, cranial facial abnormalities, so there's something wrong with the skull or the face, there's some kind of abnormality there, myopathy, that's relating to pathology of the muscle, or congenital syndrome, so some kind of syndrome that the baby was born with. The third specific cause for failure to thrive is unavailability of food. And so you want to consider maybe the parents not feeding the baby properly, so inappropriate feeding techniques, inadequate access to or volume of food, inappropriate food for age, abuse, or neglect as well. A fourth specific cause of failure to thrive is vomiting, caused by reflux, obstruction of the intestinal tract, or increased intracranial pressure. A fifth specific cause of failure to thrive is malabsorption. So what kind of examples can you think of for malabsorption that would present in a newborn baby? That also can be correlated with adults. So when you think about absorption, whether it's babies or with adults, what kind of conditions do you think of automatically off the bat? So some of the ones that you're going to think of is cystic fibrosis, biliary disease, disorders of metabolism, immune deficiency, inflammatory bowel disease, also known as IBD, and sixth, celiac disease. And so my teacher in 8th grade, she actually had celiac disease when she was little, and ever since then, I could remember the disease really well, so I'll share the story with you. But when she was younger, she was very, very pale, and she was very, very, very thin, and so she had celiac disease, and that means that, or she still does, and you're not able to consume gluten, which is rye, wheat, and barley. And so, and the reason why she presented so thinly is just because you're not able to process those nutrients. So before I am totally rambling. But at the end of the day, celiac disease can present as malabsorption. Just know that, because you're not able to digest gluten and process it properly. So you have problems processing that. I don't know if that made sense. All right, we will move on now. So diarrhea. So diarrhea is another specific cause of failure to thrive. And so this could be due to bacterial gastroenteritis, a parasitic infection, or starvation. Another specific cause of failure to thrive is increased metabolism or use of calories, which makes sense. And this might be due to several reasons. So what kind of conditions can you think of where a baby might have a higher metabolism than normal? So some potential causes of an increased metabolism are chronic or recurrent infections. So if a baby has an infection, then they're going to need to use more energy and more of its body resources, to fight this infection. And the most common is a urinary tract infection, also known as UTI. Maybe chronic pulmonary insufficiency, which also makes sense that you're not able to breathe properly, so you need to use more of your energy to kind of use those muscles to breathe properly. Congenital or acquired heart disease, neoplasm, also known as cancer, lead poisoning, chronic anemia, so lack of hemoglobin, I believe, or endocrinopathy, so that's something's wrong with your endocrine system. So something's wrong with your hormones. All right. And finally, the last specific cause of failure to thrive is defective use of calories. And three causes of that could be inborn errors of metabolism, so the baby's born with a problem with metabolizing things, renal tubular acidosis, I mentioned this earlier, relating to something. Renal tubular acidosis. I mentioned renal tubular acidosis with reflux as a cause for failure to thrive. And then finally, cyanotic heart disease. So those are all the causes of failure to thrive in a nutshell, if that was a nutshell. All right, now we're going to go into the diagnosis of failure to thrive. And so investigation centers on uncovering any known cause. Observation by a team or in a hospital setting is desired if a behavioral or psychological cause is suspected. So specific laboratory testing is needed as per history and physical exam, or PE. And so there are six initial laboratory tests that you should do. So number one will be, what is the number one test? Can you think of some tests that you'd want to do in a patient that's failure to thrive? So generally, you're going to want to get a CBC with differential and ESR, or erythrocyte sedimentation rate. So CBC is a basic blood test that we often get just to it's kind of general, right? But it gives us an overall impression, and I think for me, one of the most important reasons why we would get a CBC is to see if there's infection. And so if you have high white blood cells, that will tell you if there's infection. And then with the differential, you might hear CBC results has a left shift. And if a CBC result has a left shift, or a left differential, or left shift, or something like differential, then that is telling you that neutrophils, oh man, I'm not sure if I'm explaining this correctly, but it's telling you neutrophils are being activated in the body. And neutrophils are young white blood cells. And so if neutrophils are activated, then you know there's infection, because they're being released from the body earlier to fight this infection before they're fully mature. All right. So the second test you'd want to get to diagnose failure to thrive is a urinalysis, a UA, with culture and sensitivity. So what that means is, you might hear it as CNS, and so UA, you get the sample of the urine, and then you want to test if there's bacteria, and so you have an agar plate and you do a culture. This is the agar plate, the culture, and you swab the bacteria onto this thing, you let it grow, and then you see what kind of bacteria grows. So that's the culture, the process of the bacteria growing from using the sample that you got from the UA, the urinalysis. Sensitivity is when you have grown the bacteria. The bacteria is now growing, right? And it takes about 48 hours, I believe. And then now you need to test what antibiotic can be used to kill it. And so that's the sensitivity part of culture and sensitivity. All right, the third laboratory diagnostic test you'll do for failure to thrive is serum electrolytes, blood urea nitrogen, also known as BUN, not BUN, BUN, and creatinine. The fourth test that you want to do to diagnose failure to thrive is check the thyroid function. So TSH, that is thyroid stimulating hormone, and then T4 levels, which is thyroxine, just no T4. 5, you're going to want to do a tuberculin skin test. And number 6, you're going to want to do a radiography of wrists for their bone age. So I'm thinking that just means an x-ray of their wrist just to kind of see the age of their bones. That's what I think. All right. And treatment is pretty intuitive. You're going to want to treat the underlying cause, whatever that is, whatever you determine that to be. I went over so many of those earlier. So there are a lot to figure out. Number two, you want to remove the child from the home if necessary. So if there's a problem with abuse or neglect, something like that, then you would need to report the parent to Child Protective Services or figure out what's going on. And then finally, you're going to want to increase feedings of the infant from 100 to 150 kilogram You'll want to increase the caloric intake of infants from 100 to 150 kilocalories per kilogram per day. All right? All right, so that concludes Failure to Thrive. Good job. All right, so now we're going to move on to selected causes of growth delay. So for selected causes of growth delay, we're going to be going over three main topics. So number one will be familial short stature. Number two will be constitutional growth delay, also abbreviated often CGD. And then number three, growth hormone or GH deficiency. All right, and so let's just start talking about familial short stature. And so familial, just to break down this kind of humongous phrase, familial just means it's inherited from the parent. So it's inherited from your family, familial. And then short stature is you're short, pretty much. So familial short stature is due to a growth pattern inherited from the parent. And so generally, when is familial short stature apparent in the life of a newborn infant? So, or just an infant in general. So the answer to that is familial short stature is apparent by before the second year of life. So before the child turns 2 years old, it should be apparent because the provider should have noted on the growth chart, this baby is consistently below whatever percentile and is not growing properly, and they have a short stature. All right, and it manifests as a deceleration in height. And height is hereditary and closely matches parental height. However, we know there's a lot of instances, not a lot, but there are a few instances where there are anomalies where, the parents are kind of average height and then they have a ginormous tall, very, very tall kid. And so that just might be, somewhere in their ancestry there was a tall gene or who knows, but just know height is hereditary. All right. The physical exam, all right, child has normal development, right, without any other symptoms or signs of disease. Special testing is not usually required. It's not further workup is not required, but if there is further testing required, you want to do that to rule out other causes. So you'd want to do a CBC, as we talked about, ESR. I didn't talk about that earlier. Erythrocyte sedimentation rate. To be honest, I don't know enough to talk about it. Urinalysis, BUN and creatinine, and intrinsic growth factor IGF-1 and IGF protein binding 3. So IGF stands for intrinsic growth factor. And then the second thing you might do to test for familial short stature is radiography of the distal radius. So the way that you remember this, if this is my right hand, right? So I just remember RU for some reason. For me that works, but RU, so I think radius ulna. And so I remember my right hand, I always do this RU, and so radius ulna. And so I'm going to do the distal radius. So distal will be further away. So distal radius, proximal is closer to the origin of attachment. And so an x-ray of the distal radius will reveal bone age equal to chronological age. And then finally, how will you treat familial short stature? So you just reassurance, basically. You reassure the parents that deceleration is normal and expected, especially if both parents are short. All right, we're going to talk about constitutional growth delay now. So we went over familial short stature. We're going to go over constitutional growth delay, and then we also have, after that, growth hormone deficiency. I just got a whiff of some chemicals. Weird. All right. So All right. Wow, it's really strong and not pleasant. So, constitutional growth delay. So, the child is often called a late bloomer and may have a family history of delayed growth. Family members may be of normal height. Skeletal bone age will lag behind chronological age. So this is an important. This is a distinction that I want to make with familial short stature and constitutional growth delay. Familial short stature, the bone age is equal to the chronological age, while what am I talking about? Constitutional growth delay, the bone age will lag behind the chronological age, okay? And so this makes sense because chronological growth delay is essentially a temporary delay in skeletal bone growth. So it makes sense the bone age will lag behind or be slower than the chronological age. And thus, because you have a delay in the skeletal bone growth, then you'll obviously have a delay in height, right? And so the important thing to emphasize is that constitutional growth delay, there are no other physical abnormalities causing the delay, just the temporary delay in bone growth. And constitutional growth delay, or CGD, I might start calling it that in this video, is the most common cause of short stature in infants. All right, and puberty, since your growth will be delayed, puberty may also be delayed as well. All right, so physical exam, except for height, everything development is normal for age. And then further testing you might do is driven by the history and physical exam findings, and testing is done to rule out other causes as mentioned earlier. And the testings that you might want to do is CBC, ESR, urinalysis, BUN and creatinine, serum electrolytes, calcium and phosphorus. You might want to look at the intrinsic growth factor as well as karyotype. All right, and so you also might want to do the X-ray. Remember the X-ray as well, to show the distal radius reveals chronological age is greater than your bone age, and so bone age is slower than your chronological age. It's literally, I just said the same thing in two different ways. All right, and then how do you treat constitutional growth delay? So growth is delayed, but eventually the child will reach his or her expected height. All right, so there's honestly not really a treatment. Just be patient is all. All right, the final topic for selected causes of growth delay is, drumroll please, growth hormone deficiency. So GH deficiency. And so some general characteristics about this is the anterior pituitary gland produces GH under the stimulation of what hormone? That's a question. So the anterior pituitary gland stimulates growth hormone. Sorry, that's wrong. All right, let me rephrase my question. What stimulates the anterior pituitary gland to produce growth hormone factor? Growth hormone, just growth hormone. All right. That is going to be, very simply, growth hormone releasing hormone. That makes total sense, right? GHRH. Growth hormone releasing hormone will stimulate the anterior pituitary gland to stimulate growth hormone. Oh my God, so cool. And then it'll also suppress somatostatin. So growth hormone deficiency may be an isolated disorder, or it may be a result of another pituitary hormone deficiency. The most likely cause is idiopathic, so idiopathic meaning of unknown origin. And then other diagnoses to consider include congenital and acquired reasons. So congenital might be empty sella syndrome. Look it up. I don't know what that is. And acquired could be craniopharyngioma. So I'm thinking is some kind of tumor related to the cranium and the pharynx. All right. And growth failure caused by growth hormone deficiency, it may occur during infancy or it may appear in childhood, and is largely dependent on the underlying cause. And what is Laron syndrome? Laron. Laron syndrome. So Laron syndrome is dwarfism, and it results from a mutation in the growth hormone receptor. Okay, so maybe you can think Laron is the 8th dwarf of the Snow White and the 7th dwarfs. So it's actually supposed to be Snow White and the 8 dwarves. It does not roll off the tongue like 7 dwarfs. So Laron is the 8th dwarf. Laron is the 8th dwarf in the movie or book Snow White and the 7 dwarves, and it results from a mutation in the growth hormone receptor. All right, we're going to go over the physical exam of growth hormone deficiency now. And so you'll see, what will you see on the physical exam of growth hormone deficiency? So decline in growth velocity or subnormal growth is characteristic. Children with dwarfism have distinctive facial features. So true or false, growth hormone deficiency will present with truncal obesity. That's true. The answer is true. And can you tell me the reason why someone with a growth hormone deficiency will present with truncal obesity? So that means obesity of the trunk region. This is my trunk. So the reason behind someone with growth hormone deficiency presenting with truncal obesity is growth hormone promotes lipolysis. So that's the breakdown of fats in the body. And so if you lack growth hormone, then you're not able to break down fats properly. And so that's why you have more fat in your truncal region than average. So what about the eyes? How is growth hormone deficiency going to affect the eyes? So it might cause impaired peripheral vision, and also you can get optic chiasm tumors is also frequent with growth hormone deficiency. So your trunk is larger and it carries more fat, but also you're not able to see peripherally, so you just see very like one-dimensional like this. Okay. So this is, I've definitely talked about this in another video. So Turner syndrome, tell me to one physical feature and one other feature of Turner syndrome. So the answer is you'll get a webbed neck in Turner syndrome, and then the other one that's not physical, but you will get delayed puberty. So these two characteristics are seen in Turner syndrome. So I just thought of Tina Turner, but I also thought of Dirty Dancing, which was so random. I don't know, did Tina Turner sing a song in Dirty Dancing? But anyway, so Turner syndrome, you're going to think a webbed neck. So maybe there's a penguin. There's a penguin. And penguins have webbed feet, right? And this penguin is dancing to a Tina Turner song, right? And then delayed puberty. So but the webbed feet of the penguin relates to webbed neck in Turner syndrome and delayed puberty. So this penguin is special, and has delayed puberty. That's my story. All right, and so when you see, my question for you is, if you have disproportionately short limbs compared to this trunk, then what does that suggest? Well, that's going to suggest skeletal dysplasia. That's the answer. All right. And we're going to go over some testing for growth hormone deficiency, but essentially you're going to rule out causes as mentioned earlier. Similar tests you'd want to do. You're going to want to do the radiography of the distal radius performed for bone age. And then when other causes are ruled out and growth hormone status is equivocal, so that's saying if growth hormone status is normal, then you're going to want to investigate further and figure out what is going on with this person that's having problems with their growth. All right, and then in some cases, a trial of human growth hormone may be warranted and may confirm the diagnosis. And then how will you treat a patient with growth hormone deficiency? Well, it's pretty intuitive. You're going to give them growth hormone, human growth hormone, but it's only approved for specific causes. And so there's 1, 2, 3, 4 specific causes that growth hormone is approved for. What are they? Okay, so the first one is Prader-Willi syndrome. Will-I-am. So Prader-Willi syndrome, Turner syndrome, the Turner one we mentioned, webbed neck, and delayed puberty. Number 3 is children born for small for gestational age infants that fail to grow. And then 4th is chronic renal failure, is the 4th reason why you'd want to give human growth hormone, and that has been approved. And then obviously we're going to want to refer this patient with growth hormone deficiency to a pediatric endocrinologist. And because tests for growth hormone deficiency are often difficult to interpret, and treatment for other causes is controversial, so that's why you'd want to refer. Oh my goodness. Good job. All right. So I'm going to stop this video. So good luck studying. Bye.